will the administrator call the roll?
Mr. Chair, Mr. Vice Chair, before we do that, I just want to mention that this meeting is being recorded for the minute-taking purposes, as well as for posting of the recording on the agency's website. The meeting is also being live streamed on the Access Health CT website. It is also requested that participants introduce themselves every time they speak, and the roll call votes will be taken for every action item. With the roll call, Charles Klippel, Chair, Paul Philpott, Vice Chair.
Here.
Grant Ritter.
Here.
Deidre Gifford. Steven Hernandez. Matthew Brockman.
Here.
Thank you. Thomas McNeil. Mr. McNeil. Dina Berlin.
Here.
Thank you. Peter Hader from DSS.
Here.
Thank you. Kathleen Holt from OHA.
Good morning.
Good morning. Thank you. Claudia Gaultier from OPM.
Here.
Thank you. Paul Lombardo from SID. Dr. Manisha Jutani from DPH.
Present.
Thank you. And Carlene Zambetti, designee for Nancy Navarrete, DMS Commissioner.
Here.
Thank you.
Okay.
And sorry, sorry, Paul. I think we see Tom McNeil is here, but I don't know if he was able to respond to some March and oh, thank you. Sorry.
Mm-hmm.
Thank you. Thank you.
Mm-hmm.
Okay. Do any of the board members have any questions or comments about the minutes of the last meeting?
Mr. Vice Chair, before we do that, I think the members of the senior leadership team would like to introduce themselves.
Absolutely. Let's do that.
Good morning, all, and thank you for being here today. James Michelle, Access Health Connecticut.
Good morning, Gina Walsh, Director of Operations of Access Health Connecticut.
Good morning, Holly Zwick, Director of Finance, Access Health Connecticut.
Good morning, Rebecca McClear, Director of Technical Operations and Analytics, Access Health Connecticut.
Good morning, Susan Rich-By, Director of Legal and Governmental Affairs, Access Health Connecticut.
Good morning, Caroline Ruette, Director of Marketing, Access Health CT.
Good morning, John Carbone, Director of Small Group Product Development and Broker Support.
Good morning, everyone. Glenn Jurgen, Director of Human Resources with Access Health CT.
Good morning, Tammy Hendricks, Director of Health Equity and Outreach, Access Health Connecticut.
Mr. Chair, this concludes the introduction of our leadership team. Thank you.
Thank you. Thank you. And I'm informed by the administrator that there is no public comment. Is that correct?
That is correct. That is correct, Mr. Vice Chair. We did not receive any public comments for today's meeting.
Thank you. So that being the case, do any of the board members have any comments or questions about the minutes of the previous meeting? There being none, the chair will accept a motion to approve the minutes.
Tom McNeil, so moved.
Matt Brockman, second.
Thank you.
Is there any discussion on the motion before us? Mr. Vice Chair, would you like me to call the roll?
Yes, please.
Thank you. Charles Klippel. Paul Philpott.
Yes.
Thank you. Grant Ritter.
Yes.
Deidre Gifford. Steven Hernandez. Matthew Brockman.
Yes.
Thomas McNeil.
Yes.
Dina Berlin.
Yes.
Peter Hadler.
Yes.
Kathleen Holt.
I'll abstain as I wasn't at that meeting.
Thank you. And Claudia Gaultieri.
Yes.
Thank you. Motion passes.
Thank you. I'd like to turn this over now to our CEO, James Michelle, for the CEO report.
Good morning, everyone. I am James Michelle, the Chief Executive Officer of Access Health Connecticut, and I hope you're all doing well, and thank you for being here today. Before we begin, I would like to welcome our newest board member, Kathleen Holt. Governor Lamont recently nominated Kathleen to serve as the state's healthcare advocate. Thank you, Kathleen, for joining us. And I also would like to take this opportunity to thank Sean King as he returns to his role as the general counsel for the Office of Healthcare Advocate. Sean, thank you very much for your support and guidance over the last year in service of our mission. But let me talk very quickly about what happened yesterday. Yesterday, we hosted our annual community conference, and we host this every year about 2 to 3 weeks before we start open enrollment. And the intent with that conference is to bring all of our partners, brokers, the carriers, our DSS, our community organization partners, all the navigators, to kind of give them an update on what's coming up in the coming open enrollment and the changes that we put in place, and also give them an opportunity to ask a lot of questions. Yesterday, we were very fortunate to have many of our elected officials with us. Again, the event took place in Waterbury, so the mayor of Waterbury spoke. So did as well as Senator Blumenthal, and also Congresswoman Johanna Hayes, and Senator John Hartley, who represents the Waterbury area. It was well received. Was well attended, well received, and we also had other state agencies there to disseminate information for a number of attendees. So I want to extend my thanks and appreciation to my team, particularly Tammy Hendricks, who headed this whole effort for another very successful event. So thank you very much. And for those of you who were able to attend, Kathleen Holt was there, and I was able to introduce her as the new office healthcare advocate for the state of Connecticut. So Kathy, thank you for attending. Let me move on. To give you a quick update on the 10 Clicks project that we just started doing. The goal of this project is to simplify the enrollment process for our customers going forward. We are focusing on a new technology platform to replace our current system, which was built over a decade ago. Finally, in response to last month's request for an example of how the individual coverage health reimbursement agreement process works for employers, we will forward a one-page document that addresses that request to the board later on today. Also, we will be scheduling a training workshop for the board for us to demonstrate the new platform so the board can get a real feel for how this is going to work, and more importantly, how it's going to help employers. Employers and their employees. Regarding our meeting today, we will begin with an open enrollment 12 update. We are prepared for this important time of year, as this is our 12th one, so it's becoming a bit more routine, but every year it changes. So we have to really stay on top of what we do on a regular basis. The open enrollment begins on November 1st, 2024 and ends on January 15th, 2025. It is important that the public realizes that when they enroll will impact when the insurance kicks in the next year. So, for example, if you enroll between November 1st and December 15th, your effective date will be January 1st, 2025. And if you enroll between December 16th and January 15th, your effective date will be February 1st. So I want to make sure the public is aware of that. Katie Hearn, our Associate Director of the Enterprise Project Management Office, will discuss technology, marketing, and outreach preparation for this period. Carolyn Ruette, Director of Marketing, has put together a comprehensive marketing plan to ensure all Connecticut residents know when and how to enroll or renew their insurance with Access Health. And also, Tammy Hendricks, Director of Health Equity and Outreach, has planned enrollment events across the state of Connecticut in November, December, and January, so all people have access to expert person when they need it, where they need it. Then after that, Jackie Walker of Wakely Consulting will present this year's Consumer Impact Study and rate review. Caroline will then present the result of the recent survey about the impact of the Affordable Care Act on health and well-being here in Connecticut. We recently sent the result of this survey to the board. If you have any questions about the survey, please do not hesitate to reach out to me or Caroline. And if time allows, Susan Rich-Beyer, Director of Legal and Government Affairs, will conclude the meeting with a legal and policy update on the Affordable Care Act. A couple quick updates on that. As many of you know, the enhanced subsidies are set to expire after plan year 2025. These enhanced subsidies were first made available through the American Rescue Plan Act, and they were extended through the Inflation Reduction Act. This is the last year they will be in effect. We are working closely with the National Academy for State Health Policy, otherwise known as NASPE, to monitor for updates. And we are working to supply elected officials with helpful information to support efforts for making this financial assistance permanent. We will provide updates as more information becomes available to the board. Thank you again for being here for our October meeting. I will now pause for any questions.
Thank you, James.
Yeah.
Good morning, everyone. My name is Katie Hearn. I'm the Associate Director of the EPMO. Our department is currently tracking 17 projects, and we are meeting with all of our stakeholder departments to prepare for open enrollment 12. We're looking forward to getting started on November 1st. Today, I'll walk through some updates regarding technology, marketing, and health equity and outreach. For the technology updates, Director of Technical Operations and Analytics, Rebecca McClear, can provide any additional information. Each year prior to open enrollment, we have a system release. This year, our most recent system release was deployed successfully on October 4th. As I mentioned at the September meeting, this is the first OE in which those enrolled in catastrophic plans can be crosswalked and auto-enrolled into other qualified health plans. Catastrophic plans are typically available to those younger than 30 years of age. So now individuals aging out of catastrophic plans can be crosswalked into comparable coverage. For open enrollment, we have updated the QHP renewal options display, the screen a bit, to improve the customer experience. And this OE, for the very first time, deferred action for childhood arrival recipients will be able to enroll into qualified health plans and potentially receive financial assistance. We have some projections provided by the Tech Ops and Analytics Department at the bottom of the screen there. The first projection is for expected customers for total QHPs. But below that is for Covered Connecticut alone, and below that is for standalone dental plans. Just for some context, our current QHP members number stands at 137,958 as of yesterday. Also, I don't have it on this slide. If you want to just go back to the technology slide, sorry. Thank you. But I wanted to add an update from Plan Management. Plan Management has made some recent enhancements to the consumer portal. Member cost share amounts are now reflected for 27 of the most frequently utilized benefits. And we've added language to specify when a plan deductible may or may not apply to a covered benefit or service. These changes are part of our ongoing efforts to educate our consumers throughout the plan selection process. Thank you. Next slide, please. Now I have some updates from our marketing department. Director of Marketing, Caroline Rouette, can provide further information. Marketing is now finalizing its targeted multimedia campaign and its PR strategy. The marketing department is also finishing its direct-to-consumer content and is reaching out to Covered Connecticut members and prospective Covered Connecticut customers. And marketing has also developed brand new website content and flyers, which have been shared with our community partners to provide enrollment information for DACA recipients. Next slide, please. And the last OE update slide here is for health equity and outreach. There are many health equity and outreach activities planned in preparation for OE and during OE. If you need any more information, Director of Health Equity and Outreach, Tammy Hendricks, can provide further details. We have our online Healthy Chats open to the public each month, and also online chat and learn meetings available to our community partners each month. Another enrollment fair has been added to the schedule, so we have plenty of in-person help available this OE, 25 enrollment fairs throughout the state. We have in-person help available at our Navigator sites, and we also have ongoing help during the OE period at the East Hartford and Stamford libraries. Thank you very much.
So Paul, do you want us to move on to the next if there are if there are not any questions? I would ask board members if they have any questions about the OE update. Okay. Jackie, you're up.
Thank you. Can you all hear me okay? I'll make sure.
Yes.
Okay, wonderful. Thank you. So good morning. My name is Jackie Walker. I am a consulting actuary with Wakely Consulting Group. I'm stepping in for Julie Andrews today, but I will be walking you through the results from the rate review and consumer impact analysis report. So today we'll be covering the plan offerings available in 2025, how those rates have changed, and then also review some examples of how enrollees may be impacted by those changes. Continue on. Our plan offerings crosswalk is relatively straightforward this year between Anthem, Chi-Chi, and CBI. All plans offered in 2024 will be offered in 2025, and all plans will still be available statewide. As part of the overall consumer cost, I think it's important to understand metal tier election and the eligibility for cost sharing reductions, as this is a driver to what the consumer pays. So we'll first explain actuarial value. A plan's metal tier is defined by its actuarial value as calculated using the federal AV calculator. That evaluates all cost sharing inputs, being coinsurance, copays, deductibles, up to the maximum out of pocket, to establish the actuarial value. So the actuarial value can therefore be described as the portion of claims payable by the carrier versus the portion payable by the consumer. So for example, in a standard silver plan, as shown in the table on the bottom right, the carrier would be responsible for about 70 to 71% of medical claim costs, and the consumer would be responsible for the remainder. While for a bronze plan, the carrier would only be responsible for 61 to 65% of claim costs. Keep in mind a consumer's responsibility is limited each year by their maximum out of pocket, which does vary by plan, but may not exceed $9,200 for 2025. And premiums are not a component of what is going into the cost sharing cap. The ACA also provides cost sharing assistance to those consumers enrolled in a silver plan below 250% of the federal poverty level. Consumers that qualify may be eligible for reduced cost sharing, that being lower copays, coinsurance, and deductibles, thus increasing the standard silver AV from 70% up to 73%, 87%, or 94% AV, as represented in the graph there on the left, the red being the subsidized portion. This information, keep in mind, is independent of any state program that may impact cost sharing, such as your Covered Connecticut program. On the next slide, as of September 2024, 89.6% of enrollees are eligible for subsidies. This is compared to close to 70% of those at the beginning of 2021 before the ARP subsidies. So this slide provides a snapshot of metal level selection by enrollees through the year. The left four columns show the metal selection This is for on-exchange enrollees by year. In 2021, we actually saw a reversal of the prior year's trends with an increase in silver plan enrollment, so decreasing before 2021, and that increase has continued into 2024. The introduction of the enhanced subsidies from ARP and Covered Connecticut in 2021 and 2023, respectively, are likely a contributing factor to this increasing enrollment. The right four columns in the exhibit, if you go back real quick, thank you, show what percentage of enrollees in a metal plan have elected the lowest premium plan option available that year. This is intuitive, but given that the results are less than 100%, we can conclude that there are other factors considered when enrollees are picking their plans other than cost, as not all members are picking the lowest cost plan. And note here, enhanced and subsidies were extended under the Inflation Reduction Act through 2025. So we will expect those trends likely to continue at least through 2025. On the next slide, while discussion has been focused on individual, we did want to review small group plan offerings as well. This is on the exchange. The same carrier, Anthem, will be the only one participating in 2025 with one new platinum plan offering. As you can see, there is the only change in small group. So then we'll start getting into how the rates have changed for 2025. On the next slide, when weighted by enrollees, the average rate increase was 5.7%, and this excludes aging impact, so the expected increase in costs as someone gets 1 year older. Across all plans and areas, this ranged from 1.5% up to 15.4%. And when looking at it by issuer, we saw 6.4% for Anthem, 5.1% for CBI, and a high of 11.8% for TICHI. Silver loading does continue in 2025 for the removal of CSRs, so no impacts in the changes there. On the next slide, there are several drivers that contribute to the average 5.7% premium increase. The largest driver of increase has been reflecting emerging experience and pricing trends, which reflect an increase in the number and complexity of services sought by enrollees, and just general inflation. Trend alone ranges from 9 to 10% for both medical and pharmacy. So keep that in mind when we're looking at these rate increases. Should I go ahead and address the raised hand? Can we go ahead?
Yes, please. There is a question from one of our board members.
Thank you, Marcin, and thanks for the presentation. Just a quick question, because you had mentioned earlier the rate increase before subsidy. It's my understanding, based on some previous exercises that the board has done when we raised the assessment fee, for example, that since 80% of our exchange market on the individual side is with subsidies, that the subsidies are pegged to the premium cost. So is it true to say that by and large, 80+% of those on the individual market are shielded from any of this increase?
Yeah, we'll go over it in more detail in the consumer impact analysis. You're correct. As the premiums increase at the same time, because it's linked to a benchmark plan, that cost is increasing. They will be increasing more subsidies. Not in all cases, the premium impact is outweighed by the subsidy increase, but there are options for the member to not increase their total out-of-pocket costs, but correct assumptions from what you said.
Thank you.
Mm-hmm. Okay, and I think on this slide, the only other comment was just that federal risk adjustment program and the high risk pool continue to be the only mechanism by which issuers can mitigate any adverse experience year over year. On the next slide and the following slides, we'll be showing by carrier, metal, plan, and by county premium changes for plans continuing from 2024 into 2025. The gold plan is increasing on average by 13%. So that's much higher than the other metal levels. And the silver plans by 3.9%. If we focus on the three silver plans within the red box, Anthem silver premium is increasing 2% for Fairfield County, CBI is increasing 4.9% and Chi-Chi 11.8%. The changes to these silver premiums are doubly important as they're used to determine the benchmark premium as mentioned before, and we'll discuss further on later slides. So this slide shows the remaining bronze and catastrophic plans. The bronze plans are increasing on average 4.5% and catastrophic plans by 4.7%. As mentioned, by county across all plans, the average weighted increases vary from 1.5 to 15.4, and gold, we did see those higher rate increases this year. To switch back to small group plans for a minute, Anthem small group plans on the exchange increased on average 9.2%. So plan changes there vary from 3.6% up to 14.5%, with additional variation by rating area, so slightly higher on the small group market. So now we'll get into the consumer impact analysis. Those were the rate changes. How does it impact the members? So a little on the basics. When your consumer decides which plan to select, there are many considerations such as plan design, network, and their needs. This analysis focuses on the directly measurable impacts of changes in the premium and the federal subsidies that they're receiving. Keep in mind, brokers are well positioned to advise consumer on their needs and plan selections. And in addition, you will have the AHCT decision support tool, which also helps consumers navigate their shopping experience, assisting in evaluating their premiums and estimating costs for the upcoming year. So the premium consumer impact analysis uses weighted average calculations based on exchange enrollment as of September 2024. Note that premium changes do vary by age, county, income, plan, and household size. So this could look very different depending on which household you're looking at. On the next slide, we provide some important definitions of components that are used in evaluating the consumer impact analysis. So the benchmark plan is defined by the second lowest cost silver plan for essential health benefits only. So as mentioned, that is the driver in the subsidies that members will receive. Obviously, members can pick a non-benchmark plan, but pay the difference in cost. So ultimately, the benchmark plan and the plan selected by the consumers define the advanced premium tax credit paid by the federal government and may be referenced as the subsidy. And lastly, we also recognize that Covered Connecticut program that started in July of 2021, the impact of Covered Connecticut was not incorporated in this analysis. We're just looking at the impacts of federal subsidies. The benchmark premium plan is changing in one county only, and that is Fairfield. The remaining counties, the second lowest cost silver plan has remained the same. And the 2025 premium changes for the benchmark plans vary from 4.6% to 5%. Since the benchmark is increasing in all counties, as mentioned, the available subsidies are also increasing, but we'll look at how those offset each other. So this table presents the change in the benchmark plan and the percent premium change by county. The benchmark premiums are increasing in all counties. Remember, only Fairfield's benchmark plan is changing, and the dollar impact of these changes are going to vary by the household income and county. So now we're going to transition to a detailed example of consumer impact on a sample household made up of a single individual. So we have Michael, who is 44 in 2024, and whose income is 300% of the federal poverty level. For this individual, benchmark premiums are increasing 8%, which includes the increase due to aging, as he's going to pay a little bit more being 45 versus 44. Michael's subsidies are increasing on average 11%. However, these don't offset each other in full, and on average, his net premium is actually increasing by 3%. On the next slide, if we focus in on Michael for Fairfield County, you can see across the top row, his benchmark premium is increasing by $65 or 8%. His subsidy is increasing by a similar amount of $56 or 10%. The result is that his net premium and the benchmark premium will increase $9. So you'll see the 219 to the 220.28 over there on the far right. The benchmark plan is changing in this example for Fairfield County. So this analysis does assume that Michael would change to the new benchmark plan here.
Jackie, 1 second.
Yep.
Claudio, does that help clarify the question you asked earlier?
Yeah, this is a great, I love this chart. I think it's
Okay.
so clear for understanding how the different moving parts are potentially working in tandem. So thank you, appreciate
Okay.
it, and appreciate the moment to comment. Thanks.
Thank you, Jackie.
Thank you. All right, so the next two slides, we'll be reviewing a couple of shopping scenarios, following Michael through enrollment in the lowest cost silver plan because the benchmark plan is based on the second lowest cost. So we'll be looking at the lowest cost silver plan as well as the lowest cost bronze plan. What does that look like for Michael? So the next slide will be following through the lowest cost silver plan. The lowest cost silver plan is remaining unchanged for all counties from 2024 to 2025, except for Fairfield County. So the premium for the lowest cost silver plan in Fairfield County is increasing by 8% or $65. After tax credits, there is a net premium increase of 5% or $10. Since the lowest cost silver plan is changing in Fairfield, there is a shopping opportunity. He could switch to the silver PPO standard pathway plan in 2025 and actually reduce his net premium by $13 from $218 to $205. So the goal of this, right, is to say that if a member stays in their current plan, they might see a slight decrease or a slight increase, but if they're willing to shop around and go to the lowest cost plan, that they could actually see a net premium decrease. On the next slide, we're looking at the lowest cost bronze plan is changing in some counties for 2025. In our example, we've assumed they will auto renew or select the 2025 lowest cost bronze plan, which is the same in all regions, except for now Fairfield, Middlesex, and New Haven counties. The premium for the lowest cost bronze plan in Fairfield County will be higher by 8% or $54. After the tax credit, there is a net premium decrease of -1% or $1. Since the lowest cost bronze plan is changing in Fairfield, there is another shopping opportunity. He could switch to the bronze HMO pathway enhanced plan in 2025 and reduce his net premium by $6 from $116 to $110. So now I'd like to present two more examples, though not as detailed, to just demonstrate how consumers can be impacted differently and the varying options they may have to mitigate an increase in premium. So in this example now, Ted is currently 28 and has an income at 200% of the federal poverty level. Ted is currently enrolled in the lowest cost silver option, and he is eligible for cost sharing reductions based on his income. On the next slide, we can see some options. So Ted's current premium is $48 in 2024. They're in the yellow. If he does nothing and auto renews into the same plan, his premium will go up by $3 to $51. So Ted could switch to the lowest cost silver plan, which would reduce his premiums by $14. They're in the green. Ted could switch to the lowest cost gold plan. However, this would increase his premiums by $46. Additionally, because Ted is eligible for the cost sharing reductions, moving from his current plan, which has an AV of 87%, to a gold plan, which has an 80% AV, this would actually mean higher cost sharing for him in the forms of copays, coinsurances, and deductibles. And using Wakely's proprietary database of individual ACA claimants, after considering both benefit design, induced utilization changes, et cetera, we estimate the out-of-pocket cost for those members based on the plan design and found that a consumer like Ted would have monthly out-of-pocket costs of $77 in a gold plan, which is $47 more a month than his current plan. And likewise, Ted could switch to the lowest cost bronze plan, reducing his premium to only $1 per month. But similar to the gold plan, enrollment in the bronze plan would likely mean more out-of-pocket cost sharing, and in this example, $41 per month. Keep in mind, Wakely will be providing a larger report, which includes additional household scenarios for couples and families and contains more comprehensive information. Lastly, I'd like to present Karen's situation, which is a bit unique. And before I hop in that, Claudia, you have a question?
Yeah, I think you may be getting to this, or maybe the expanded examples that you alluded to will cover it. But we took a case-by-case scenario in Fairfield County where there was an added wrinkle of the benchmark plan, which is the peg for the subsidies, changed. Assuming, could you sort of just walk through at a very high level, if that individual had stayed in Hartford where there was no change and they were in a silver plan and they stayed in a silver plan, how would that roughly have worked out? Would it have been a net wash approximately?
And just to clarify, you're saying that their premium just changed because of them moving from county to county. Is that what you're saying?
No, that they were always, it was just a person who lived in Hartford. So there was no change in what the benchmark for that county was.
Ah, okay. Yeah, I think we're talking about just dollars, right? I mean, it would be sort of like the examples that we were talking about before. If I'm understanding your question correctly, you're just asking that if they work in a different county, but sorry, maybe I should.
No,
Claudia,
let me go through it. So Jim, we'll say Jim is in Hartford County. He's enrolled in the silver benchmark plan currently. In his county, the silver benchmark plan stayed the same. So the one he's enrolled in is the silver. The subsidies will go up, presumably by the amount that silver now has gone up because it's the benchmark silver.
Yeah.
He wouldn't have an opportunity necessarily to shop, but he would stay in his existing plan for net zero change.
Okay, got it. So without any change, if he doesn't shift plans, we're talking about like a couple of dollars increase, just a couple of dollars. So I think it was back to maybe those examples like a few back when we're just talking about without the shopping. If they don't shop around, if they stay in the benchmark plan, the subsidies don't completely offset the change in premium. So he does have a couple dollars increase due to that.
Okay, thank you. Perfect.
Mm-hmm.
Just to remember, there's always the subsidy goes to the EHB portion of premium, and all of our plans, even the silver plans, usually have a few small benefits, very small, that are above EHB. So to Jackie's point, there's always going to be that little slight difference.
That's a little delta. Perfect. Thanks for that extra.
Thanks for clarifying,
Susan.
Okay, so Karen's situation is the last, currently 55 and has an income in excess of 400% of the federal poverty level. So she is enrolled in the lowest cost silver option that's available to her. Prior to the passage of the American Rescue Plan Act and the Inflation Reduction Act, Karen would not have been eligible for subsidies at an income level that she currently is at. And keep in mind, as of today, these enhanced subsidies are set to expire in 2026. So 2025 will be the last year and that she is eligible at this point. On the next slide, Karen's premiums after subsidies at the beginning of 24 are $459. If she does nothing and auto renews into the same plan, her premium will go up $4 to $463. So again, talking about the shopping options, Karen could switch to the lowest cost silver plan, which would decrease her premiums by $32 to $427. Karen could also switch to the lowest cost gold plan, which would increase her current premium by $93 to $552. though there are fewer benefits of gold plans in 2025 from a purely cost perspective. Karen would also benefit from a richer AV, though, of the gold plan at 80% as compared to the silver option of 70% AV if she was not cost share reduction eligible. So her estimated monthly out-of-pocket healthcare costs would decrease by $6 from $124 to $118, as shown on the bottom row of the table. Karen could switch to the lowest cost bronze plan, reducing her premium to only $272 per month. Her cost sharing would then increase by moving to the less rich bronze AV of 65%, but the impact is relatively minimal. Combined net premium estimated monthly out-of-pocket cost would be $404, that being $272 plus the $132, and would be lower total cost as compared to the silver options. And when thinking about that average out-of-pocket cost, we do consider the demographics of the population, the benefit design, and induced utilization for those members. So keep all that in mind. There are, of course, many considerations that would go into Karen's plan choice besides cost. Karen should work with her broker or utilize the decision support tool to weigh the best option for her in 2025. And consider the expected removal of ARP subsidies in 2026. Karen's situation may look very different going into next year. And that covers our material. This slide just discusses Wakely's disclosures and limitations. So just want to open for any other question from the material.
Any questions from the board?
I'll make it a trifecta. This way I'm all set. Going back to an earlier slide, you had broken down the number of people who were in bronze plans. Knowing that I think the board has talked about this a couple times previously, that there still remains a pretty significant number of people in bronze plans. And our assumption has always been that the vast majority of them may actually be missing out on cost share reduction subsidies if they went into a silver plan. Do you have any breakdown by demographics of what the bronze selectees, the people who are on bronze plans, are in terms of income, and whether that is the case, how many people on bronze are forfeiting the cost share reduction subsidies that would be available under silver?
It's a good point. I don't have it on hand what that division would be, but the 24% that I'm seeing that were enrolled in bronze in 2024, we could break that out into who's eligible for CSRs versus not, and have that as a follow-up, if that would answer your question.
And Claudio, we also have that information as well, and so we could do that analysis and get back to you, to the board, get back to you with that one. We've done that. We've looked at that in the past, identified folks who may be eligible for co-sharing, but they're still picking a silver plan. They're still picking a bronze plan, and we have some soft stops on our website. If you are eligible for a co-sharing plan, and you choose not to exercise it, we do something. We have a pop-up. At least we used to have a pop-up. I'm pretty sure we still do. That tells you, hey, you know what? You may be leaving some money on the table.
Right.
Are you sure you want to do that?
Yeah, James, and I'm thinking exactly to that point, because we've had the discussion. I know you guys have taken some interventions to make it more of a nudge, to nudge people in CSR. So it would be good to look at year over year, are some of the interventions working? What else can we do in that space to more call out a benefit that may not be taken advantage of? Or maybe the data for this year will show that some of those pop-ups and outreach work is working, in which case we could sort of lean in on that and continue to see progress. So I'd welcome any feedback, James, that you have, or if Wakely has it readily accessible, I would be very interested in that.
And we also do some direct connections with we send email notices to any bronze plan holder to advise them to shop and compare that they may benefit from. Again, we do that directly to all bronze members, to all bronze policy holders, to encourage them. So we'll do the analysis and we'll see what the trend looks like, and we'll get back to you and the board, Claudio.
Okay, are there any other questions on the board? All right, there being none, I'll call on Caroline Rouette for the Affordable Care Act survey.
Thank you. I'm Caroline Rouette, Director of Marketing at Access Health CT, and I have the pleasure of sharing some recently conducted research with you today. First, we'll talk about what we did and why, as well as how, and then we'll dive into our learnings and what we're doing in regard to next steps based on what we've learned. So in terms of our objectives and what we were looking to learn on the left-hand side here, first, we really wanted to understand, now that we've been in business and helping Connecticut residents earn coverage over the past decade or better part of a decade and more, does coverage work? Specifically, has qualified health plans or Husky D coverage over time impacted the perceived health status and well-being of our customers? So really, we were looking at the Affordable Care Act and whether or not it improved the health and well-being of our Connecticut residents that not only have qualified health plans through the exchange, but also those who have Husky D, right? Because that's the portion of Medicaid or our Husky Health program here in Connecticut that was expanded as a result of the Affordable Care Act. We were also looking to learn whether ACA essential health benefits are valued and whether or not they're utilized. That was a big tenet of the ACA, so we were looking to understand that and its usage. Third, we were looking to see if there are any gaps in coverage or barriers to access and plan utilization, and of course, how we can improve in general. Over on the right-hand side here, you'll see, oh, I'm sorry, please go back, who we surveyed. We conducted this research in May of 2024 to Access Health CT customers that were either in qualified health plans or Husky D for the past consecutive 5 years. We really wanted to know how the impact has been for customers who have been with these plans for a while. We made sure that we were speaking specifically to healthcare decision makers, and we received 360 total responses. So I'm going to pause here quickly. We did work with our research partner, Market Street Research, to confirm that that was a statistically significant number of responses. And I will also call out here that there were demographics, right? Nearly 60% of our responses were from white folks, 24% Hispanic, and 8% Black or African American. Interestingly, it's roughly similar to the population of Connecticut there. That wasn't our intent, but something that we wanted to call out. And 77% were English speaking, 20% were Spanish speaking, and 3% were bilingual in English and Spanish. And we did confirm with our research partners that that was also a statistically significant response rate for Spanish speakers, making sure that that was an important part of our data set. For the sake of time here, folks, I won't go through the rest of the demographics here, but they are available for you to read at your leisure. We did send out this full report, including this executive summary, as well as all of the deep data set and the questions that were asked to the board. Kathleen Holt, I'm not sure that that went to you, so I will confirm with the board administration following this presentation to make sure that everyone is in receipt of that information. And we can move forward now, Margin. Thank you. All right, so what did we find with this research? The first of three findings that we're going to share with you is that among our study population, we are fulfilling our mission. Access to coverage works. A couple of great statistics that we want to point your eyes to, although there's many more here. 96% of those agreed that having coverage has improved their general well-being. 79% say their health would be worse without this coverage. 74%, so almost 3/4, agree that they use healthcare services more frequently because they have this coverage. And interestingly, roughly the same amount, right? Roughly about 1/4 felt that their monthly premium was reasonable. That sounds a little off to this group. Please remember that this did include QHP as well as those Husky D folks. So there is some Medicaid included in here. Next slide, please. Our second finding was that among respondents, ACA essential health benefits related to that regular health maintenance as well as preventive care were the most valued, highly utilized, and viewed as positively impacting health and well-being. So those types of things included preventive care, prescription drugs, lab tests, and emergency services. And then third, this is really where we want to dig in. While access was easier for most, we found some customers did not use or were unable to use some of their coverage benefits. Reasons included concerns about cost and inability to find a doctor that accepted their coverage. But other concerns included mistrust of healthcare professionals, lack of transportation, not knowing where to turn, right? So we're seeing some social determinants of health pop up here. So we're going to dig into that just a little bit deeper. The column on the left-hand side, reasons that folks reported that they were unable to get the healthcare that they were needed. You'll see that N43. What that means is it's 43 people who responded of 360 said they had a problem. So the percentages below are the percentages of those 43 people, not the full set of respondents. So 47% of those 43 people who had some issues said that they couldn't find a doctor who took their insurance. 44% were worried about cost. 21% just don't have a doctor and don't know where to go. 16% had a distrust of doctors and medical professionals. 5% didn't have transportation. 2% had difficulty finding someone who could speak their language. And then 14%, interestingly, that's 14% of those 43 folks did say that they had trouble getting healthcare coverage that they needed, but they didn't supply a reason. So we did want to make sure that we at least included that for clarity. We also asked folks, hey, what are you looking for more? What can we do better? And so there's a little bit of a customer wish list here. First on that list is that folks are looking for dental and vision coverage. So our takeaways here is that, some folks might not understand some of the dental and vision that are included in many of the plans available. That's something that really has evolved over time. And so they might just not be aware of some of the benefits that they have, or that we need stronger benefits in those coverage areas as offerings. Folks also wanted more expansive coverage, so more benefits. 9% wanted more providers who take their insurance. 8% cited that they want more affordable premiums or copays. 7% asked for access to alternative treatments, and 5% want better access to specialists. They felt that that was an issue. Go ahead and advance the slide, please, Margin. All right, so this is where we'll leave you. We'll share some insights as well as what we're doing moving forward. First, most customers indicate that their coverage is improving their health and having a positive impact on their lives. This is a great message. And so we're really going to use the learnings that we find that we shared with you, but also some deeper level learnings throughout the presentation to provide and refine messaging for creative marketing campaigns. Secondarily, preventive care is highly valued, right? That's really great to hear. And those seeking family care may have some difficulty with access. That was another thing that we learned throughout the presentation. And so we really want to make sure that we're expanding our outreach efforts to include health literacy and address those social determinants of health that we're popping through, right? And it's really important to note that our efforts are in large part working with community partners that help us reach those populations in a trusted way. Similarly, some customers desire easier access for more specialized care. And so again, we're going to work with our community partners and expand our health literacy and outreach efforts to address those social determinants of health. And then lastly here, some report difficulty finding healthcare professionals that accept their coverage, and many are concerned about the cost. So we are going to work collaboratively here at Access Health CT. We are releasing a revised approach to comparing plans this year, some new documentation that hopefully can help people understand that first dollar coverage and what they can use without having to pay towards the cost of their deductible. But we're also going to share feedback with the Department of Social Services for additional areas of opportunity, collaborate with a lot of different organizations as we see fit. And I would like to add here that the Department of Social Services was included in our research process, the questions we were asking as the reporting was being completed. This is a collaborative effort. And so we're not just looking to share the results collaboratively, we are inviting the Department of Social Services into our research process as well, that hopefully will help us address these issues collectively. We'll pause there for any questions.
Any questions from the board?
Yes, Mr. Vice Chair, Deputy Commissioner from DSS, Mr. Peter Hadler has a question.
Please.
Hello, thank you, Caroline. Really appreciate the collaboration with DSS on this and the results. Just I have one overarching question about this, which is, do you have the results split out by the different types of coverage? I would be curious to get some insights if there's a critical mass of the survey respondents who may have been enrolled in Medicaid versus Cover Connecticut or QHP, to see if there's any differences in the responses, about whether certain populations are having differing experiences, and whether there's any insights to be gained from that. So I think if there's a way of splicing out the survey data to sort of see what the folks who are enrolled in Medicaid were saying versus those who are enrolled in QHP, that might be enlightening.
Sure. I don't remember off the top of my head. I know that we have a long, lengthy deck, so let me go back and double check on that. And if we don't have that, we might be able to get it. So please bear with us, but we will certainly follow up and answer that question and make sure that the group has that information as well.
Thank you.
Additional questions?
So Paul, just one follow-up comment to Caroline's presentation, that the Broker Academy is one of the steps we took early on, knowing that these were challenges that some folks in the communities were going through. From the first study we completed back in 21 and 22, the Broker Academy, I think one of the findings is that people don't know where to turn. They don't have access to information. So creating licensed brokers that are knowledgeable in the healthcare process and from the communities that were very clear about the challenges they have is one of the drivers of creating the Broker Academy. We think that's paying dividend. But again, we got to continue the Broker Academy to create more brokers in those communities that are challenged with a dearth of information. I just want to put a plug in for the Broker Academy, why we're doing it and why we're going to continue to do it. That we think that there's a need, continues to be a need, and we will continue the program to help those who don't have access to information at this point.
That's a great plug, James.
Thank you.
At this time, I'm going to ask Susan Richby to give us an ACA policy and legal update. Susan, I know you usually get cut out of the agenda, but you're on now.
Come on now, I have 3 whole minutes. Thank you very much, Mr. Vice Chair. Susan Richby, Director of Legal and Governmental Affairs. I'll go through this quickly. Braidword versus Becerra is the case that we have been following for quite a while. This is the one challenging the preventative services mandate in the ACA that started in a court in Texas. The Fifth Circuit Court of Appeals did rule back in June, and they held that the U.S. Preventative Services Task Force, they upheld that part of the lower court's ruling that those recommendations were unconstitutional. But the good news is they limited it to the defendants in the case and did not issue a national stay. So it is not a national stay right now, and they actually sent it back to the lower court to review the other recommendations of the case. So for now, that's good news. But obviously, the challenge does continue. If you go to the next slide, Marcin. As James mentioned earlier, this is something we've been following very closely and working with our colleagues at the other exchanges through the National Academy of State Health Policy. Hopefully the extension or making permanent the enhanced subsidies under the American Rescue Plan Act that were continued in 2022 under the Inflation Reduction Act. We know, as we looked at the presentation by Wakely, how important those enhanced subsidies are to getting more people covered, and also for people to be selecting a higher level of more comprehensive coverage, because those subsidies really do help make a difference. So efforts are underway in Congress. There were congressional letters of support from the House and Senate. Our delegations signed on. We also signed on to support letters with the other exchanges on this. There was a hearing held by the Senate Finance Committee on continuing the entire Inflation Reduction Act, so not just the enhanced subsidies, back in September. And right now, what our folks in Washington are telling us is that they need to really build a greater awareness for the need to make them permanent, the real impact that will happen if these are not extended past 2025, which is the last plan year that we were looking at in the Wakely presentation, that there would be a big change for 2026 if they're not extended. And then Marcin, if you just go to the next slide, please. Finally, because this is an election year, as usually happens, and there will be a change of administration regardless of who wins the election, HHS always works to get the notice of benefit and payment parameters out early, and it was released on October 4th. This is the rulemaking that the agency will do for the coming year, meaning 2026, for both exchanges and for issuers. The comment period's a little shorter. The comments are due by November 12th, so we'll be working on reviewing the rule and submitting comments. The final rule is likely to be out in early January before the change of administration. And generally, this notice of benefit and payment parameters builds on the efforts that the Biden administration has been doing over the last 4 years to expand access to affordable and comprehensive coverage, excuse me, while also reducing administrative burdens and advancing health equity. All things that we here have been working on very hard as well. So with that, I will turn it back to you. We're just 1 minute over, James and Paul. Thank you.
Thank you, Susan.
James, anything on future agenda items?
Just three quick items. Our call center RFP. We are reviewing the responses now. So we are looking to go live with a new vendor by July of next year, of 2025, and also our Tank 6 project. As I mentioned earlier, the other one is the ICHRA, individual coverage health reimbursement agreement that we are going to do soft launch on July 1st of this year, and we're going to schedule a demo for the board, hopefully within the next week or so. And finally, we have a number of audits that are going on that we'll be presenting to Claudio's committee, finance committee, in November, and ultimately to the board as well. So those are the big items going forward, and not to mention open enrollment in about 2 weeks.
Thank you, James.
Thank you.
Are there any additional comments, questions, anything for the good of the order? There being none, we'll entertain a motion to adjourn.
So moved.
Do we have a second?
Tom McNeil, seconded.
Thanks, Tom. Marson, would you call the roll, please?
Yes, Mr. Vice Chair, Charles Klippel, Paul Philpott,
Yes.
Grant Ritter,
Yes.
Deidre Gifford, Stephen Hernandez, Matthew Brockman, Thomas McNeil,
Yes.
Dina Berlin,
Yes.
Andrea Barton Reeves.
Yes.
Thank you. Kathleen Holt.
Yes.
Thank you. And Claudio Gualtieri. Thank you. Motion passes.
Thank you for your participation, and the meeting is adjourned.
Thank you all very much. Have a great day.
Thank you, you all.